Dr. Burman earned her medical degree from the University of Washington School of Medicine and performed her residency in internal medicine at Columbia Presbyterian in New York. She did her fellowship in Gastroenterology and Hepatology at University of California, San Francisco, and holds a board certification in internal medicine, subspecialty of gastroenterology. In addition to her practice, Dr. Burman is currently head of the Gastroenterology section and is the Director of Education and Training for the Digestive Disease Institute. Her talk this morning is titled, "The Many Faces of Steatohepatitis, Fat and Booze in the Time of COVID." Dr. Burman.
Great. Thank you so much. And thanks for the invitation to give grand rounds this morning. It is a pleasure to be able to think through this topic of fatty liver in sort of a different way, trying to think more in terms of case-based learning and really covering the breadth of steatohepatitis or fatty liver, including both non-alcoholic and metabolic and alcohol-related liver disease. So a bit ambitious, but here we go. So our objectives, we're going to learn to appreciate the rising burden of fatty liver, learn how to diagnose and risk stratify patients with fatty liver with a focus on primary care, recognizing mixed alcoholic and metabolic liver disease, acknowledging rising rates of alcohol dependence and alcoholic liver disease really across the spectrum, but in particular among women, and understanding the impact of COVID-19 on obesity and dysfunctional drinking. So we'll go through three cases. I'm just going to introduce them now. Case one is Elena. She's a 36-year-old from Honduras with type 2 diabetes, a BMI of 34. She does not drink alcohol. She has a strong family history of cardiovascular disease. And she presents to her primary provider with gallstone pain and is found to have fatty liver on ultrasound. Case two is a 62-year-old Korean-American executive with hypertension, dyslipidemia, type 2 diabetes, a BMI of 41, and he drinks about 3 to 4 whiskeys per day. You can see his liver enzymes are elevated and his ultrasound shows not only a fatty but a nodular appearing liver. And case three is Cheryl. She's a 54-year-old white mother of 3 who presents with mild jaundice and upper abdominal discomfort. Her primary care doctor sends labs and she has a bilirubin of 3.3. She previously was drinking about 2 heavy pours of wine per day, and during quarantine that increased to 1.5 bottles of wine daily. So we'll go through these patients, and we're going to start with non-alcoholic fatty liver disease and a bit of a history lesson to start with. So NASH is a relatively recent part of our medical lexicon. Back in 1849, an Australian pathologist first hypothesized that cirrhosis could result from fat accumulation, but it wasn't until 1962 that hepatitis of the fatty liver was first described. 1980 was the big year for fatty liver in that a landmark case series out of Mayo Clinic by Dr. Ludwig added NASH and NAFLD to our medical lexicon. So that was sort of the first time that we were really labeling these as clinically relevant and independent entities. However, it wasn't until the 1990s that we really started to realize that NASH, which was generally considered a benign condition, actually had a very high rate of progression to cirrhosis with associated morbidity and mortality. And that a lot of the cases of so-called cryptogenic cirrhosis were actually the result of sort of burned out fatty liver. In 2016, NASH overtook hepatitis C as the leading indication for liver transplant among baby boomers and women. And in 2020, we'll talk about this a little bit, there has been a movement to actually change the lexicon, to change non-alcoholic fatty liver disease to metabolic associated fatty liver disease. And we'll sort of talk about why that's come about and what that means. So in terms of epidemiology, this is fairly straightforward. 40% of U.S. adults are obese, and obesity is the #1 risk factor for fatty liver. So accordingly, we're seeing a dramatic increase in the incidence of fatty liver over 5-fold since 1995. NAFLD affects 80 million plus Americans. NASH affects somewhere around 16 to 17 million Americans, and NASH cirrhosis somewhere around 3.3 million Americans, though these are likely underestimates based on the fact that NASH is a biopsy-proven diagnosis, and we don't biopsy everybody that has fatty liver. As I mentioned, NASH has become the leading indication for transplant among women, the second leading for men, and there's been a 7-fold increase in transplant listing for NASH in the past 2 decades. Concerningly, we have not seen the peak of this epidemic. So it's predicted that by 2023, rates of decompensated cirrhosis are predicted to increase by 168%, rates of liver-related deaths by 178%, and incident liver cancer by 137%. So this is going to get worse before it gets better. What about defining fatty liver? Well, how do we even know that somebody has NAFLD? Because screening for fatty liver is not currently recommended by any of the U.S. societies, even for the highest risk patients. The thought is that it's not cost effective, and at this point there's a lack of effective therapies, so getting somebody screened doesn't necessarily translate into improved care. NAFLD is often, henceforth, diagnosed incidentally. So oftentimes through a CT scan or an ultrasound that shows, fatty liver. However, it requires 20% or more fat in the liver for us to pick that up on imaging. And in terms of elevated ALT, this is often a motivator to get further imaging. But ALT may be normal in up to 50 to 80% of people with NASH and NAFLD respectively. And we know that the degree of liver enzyme elevation has no correlation with severity. So relying on an elevated ALT to get someone screened and diagnosed for fatty liver is probably going to lead to an underdiagnosis. So fatty liver is an umbrella term. So the way I explain this to patients is that there is a spectrum of fatty liver, and on one end there is benign steatosis, where fat cells accumulate in the liver but don't necessarily cause enough inflammation. On the other side of the spectrum is NASH, or non-alcoholic steatohepatitis, which is essentially when the fat starts to cause a necroinflammatory response which can lead to scar tissue. And of course NASH can then progress to cirrhosis. But this isn't a linear pathway, so people don't just go from steatosis to steatohepatitis to cirrhosis, and we think that people are sort of predestined to go down one pathway or the other, so that you either have benign steatosis or you have steatohepatitis, and you'll probably stay in those pathways. So these are really different entities. A recent study showed that less than 50% of primary care providers reported knowing the difference between steatosis and steatohepatitis, yet 60% of these same providers reported that they were managing these patients. So it's really important that we have more clarity on these terms. So why does it matter, steatosis versus steatohepatitis? Well, one condition is benign and one condition can cause you cirrhosis and cancer. So less than 1% of patients with steatosis will develop fibrosis, whereas 25% of patients with NASH will develop cirrhosis. So these are very different kind of pathophysiologic and prognostically important entities. So if we look at this kind of big circle of all U.S. adults, assuming that about 35% of U.S. adults have fatty liver, about 3 to 5% of U.S. adults have NASH, and somewhere around 30% of these patients will have advanced fibrosis. We're really trying to hone in on diagnosing the smaller and smaller circles because these are the patients that will present with clinically significant disease. Understanding that fatty liver is essentially the hepatology or the hepatic manifestation of metabolic syndrome. All of this is underlied by insulin resistance. And it's important to just remember that this is a piece of the puzzle, and that for patients with fatty liver who are not going to die of liver disease, steatosis, non-NASH, these patients die of cardiovascular disease. But even in patients with NASH and cirrhosis, still the number one cause of death in these patients is cardiovascular, followed by cancer, followed by liver disease. So it just really underlies the fact that these are, this needs to be managed in a multidisciplinary kind of team medicine manner, and that the liver isn't the only concern we have in patients with NASH. So drivers of steatohepatitis, who is more likely to have NASH versus steatosis? Higher the BMI, the more components of the metabolic syndrome, presence and severity of type 2 diabetes, dyslipidemia, hypertension, sleep apnea. There are genetic components to this, so PNPLA3 is probably the most well-known and well-studied polymorphism that is associated with an increased risk of steatohepatitis. We think about dysbiosis and the intestinal microbiome, intestinal permeability as probably contributing, although this is sort of in the infancy of being studied. And in terms of nutritional and behavioral aspects, drinking alcohol and eating a diet high in cholesterol and fructose is probably the most modifiable in terms of risk factors. And in terms of mitigating factors, it's really only exercise and the addition of coffee that have been shown to decrease the risk of steatohepatitis. So most of you have ordered a study for one of your patients, and it pops up in the impression section that this patient has an echogenic liver, most likely reflecting steatosis, and if the patient has not already been evaluated, consider hepatology consultation. So this was an intervention by our radiology department about 8 years ago because of the increased incidence and the fact that when steatosis was sort of buried in the results section, in the past, we would actually say that this was a negative exam, and there was nothing in the impression section that really flagged an ordering provider that this was a significant finding. So we have been recommending hepatology consultation, but what do you do in this situation when you get this result? Well, you can check labs. And if the patient has an elevated ALT, you're going to want to rule out other etiologies. Fatty liver is so common that it's often a concomitant liver issue. You want to assess risk factors. What are this patient's risk factors for steatosis? Are they a drinker? Is this really not non-alcoholic fatty liver? So we looked at the yield of this intervention, this sort of tag to increase recognition and further workup of fatty liver. And so we conducted a retrospective review, and we looked in particular at the proportion of patients that were eventually seen in hepatology clinic. Of those referred, what proportion and really what were those patients that had advanced fibrosis based on invasive or non-invasive staging, and what were the predictors of NASH with fibrosis. So we looked at 812 charts. We found that the minority, 236, were seen by hepatology, and the majority, 576, were not eventually seen. Either they were not referred or the patient did not follow. But of these patients, 326 did have steatosis acknowledged by the ordering provider, and it was recommended to consider lifestyle modifications. But 250 of these patients still had no acknowledgement of this new diagnosis that we could find anywhere in the chart. For those seen by hepatology, so 29% of the total, we performed further staging on the majority of these patients, and 1 in 5 had stage 3 or 4 fibrosis. So this is actually a pretty high yield in terms of the patients that we're seeing diagnosing significantly advanced liver disease in patients that this was an incidental finding. So this just goes to show that we probably are missing more of these patients and those that were not referred, but that also we can think through really those predictors of advanced fibrosis to decide who really needs a hepatology consultation and who does not. Interestingly, we found that it was basically only patients with an elevated ALT that were sent on for further care. So if you had a normal ALT, it was less likely that you were referred to hepatology, though we know that ALT is not a predictor of fibrosis. On the flip side of that, patients with type 2 diabetes were not more likely to be referred, even though we know that diabetes is a strong predictor of NASH. So this is a key opportunity for basically earlier diagnosis and intervention, and we do want to continue to ensure that we are following up on patients that are incidentally found to have fatty liver, because it can be a very significant finding. And we know that overall there's fairly low awareness of fatty liver. Despite its incidence, it remains underdiagnosed and underrecognized. And it happens all the time that patients are incidentally found to have even cirrhosis from NASH. So this sort of underappreciation, including the spectrum of disease and how it can be sort of further assessed and risk stratified, is really across the board. But I would say that this is based on kind of more national data, and I think that our primary care team here at Virginia Mason is actually quite honed in on fatty liver. And I just want to sort of increase the awareness overall, and then help you really decide which patients may be at higher risk, and thinking about how lack of awareness may impact patient progression. So how can a primary care doctor risk stratify these patients with their basic clinical information? So as I mentioned, we're going to check labs, assess risk factors, assess alcohol use, and then we can calculate what's called a NAFLD fibrosis risk score. So with fatty liver, the pinnacle is going to be in terms of our diagnosis. So it's been very difficult for us to identify patients with NASH versus steatosis based on non-invasive biomarkers that are not only readily available but also not expensive. So the two tests that perform the best are going to be the FIB-4 score and the NAFLD fibrosis score. We mostly prefer the NAFLD fibrosis score because it has a higher negative and positive predictive value, and it incorporates more kind of clinically relevant information. So age, AST, ALT, platelet count, BMI, albumin, and the presence or absence of diabetes. And you can just plug into your MedCalc these basic clinical parameters, and it will give you either a low probability of advanced NASH, an indeterminate, or a high probability. And that's basically the most important information that we can think about to put people either in a pathway of following up with primary care or needing a potential hepatology referral. So based on this and the fact that we were seeing a lot of patients with benign steatosis in liver clinic, which is fine, but we incorporated the NAFLD fibrosis score into the radiology tag. So you may have noticed that in the past 3 months, that impression section with the incidental finding has actually been changed or updated to reflect the importance of calculating a NAFLD fibrosis score for risk stratification. So we'll also study what this means in terms of who we're seeing in hepatology clinic, and are we improving even that yield of 20% rate of advanced fibrosis. So this is my favorite algorithm for kind of further assessment of fatty liver. This was published in Gastro last year. So the first line is really your primary healthcare providers, and they can either rule in or out advanced fibrosis with these simple scores. So if a patient is at low risk, you can talk about lifestyle modifications, weight loss, exercise, and then repeat this testing at a year to determine if they need to have further evaluation at that time. If they have a higher indeterminate NAFLD fibrosis score, then we like to see those patients in liver clinic, and we've got some options in terms of how we can understand more about their not only current state or stage of liver disease, but what risk they may be for progression. So in terms of staging options, in the past, the gold standard, of course, was a liver biopsy. But for the most part, we're able to avoid liver biopsy in these patients unless A, we think they're a good candidate for a clinical trial, or B, there is some thought of an overlap or multiple kind of drivers of liver injury. For more straightforward patients, we can think about doing a fibroscan or an MR elastography. A fibroscan is a bedside test. It takes us 5 to 10 minutes. It's cheap, it's painless, but it does not, unfortunately, perform quite as well in patients with fatty liver, and in particular patients with a BMI above 30. MR elastography is really our go-to for these type of patients, and what this shows us is not only the percent fat in the liver, so it gives us a really good sense of the severity of steatosis, but it shows us from stage 0 to stage 4 where patients are in that spectrum, and it gives us a great amount of baseline information. Because if there's only one thing that you know about your patients with fatty liver, it is the degree of fibrosis. Because fibrosis is the strongest independent predictor of disease progression. 1 in 5 patients with advanced fibrosis will develop cirrhosis within 2.5 years. So we really just want to know if our patients have fibrosis or not, because fibrosis is a proxy for NASH, right? Because steatosis does not lead to fibrosis, steatohepatitis does. So we can skip the biopsy if we just know if a patient has fibrosis or not, and if they have predictors of developing fibrosis in the future. So back to our case 1, Elena. So we are seeing a rising burden of NASH and cirrhosis among Hispanic or Latino Americans. So we'll talk a little bit about that. But we want to evaluate this patient further because she has a high NAFLD fibrosis score. So she comes into liver clinic and we end up doing an MR elastography. And this is what the MR reports look like. So it shows that her average shear stiffness is abnormal at 3.6 kilopascals, which is equivalent to a stage 2 to 3 fibrosis. She has a fat fraction that's elevated at 26.4%, which would be considered moderate to severe. But this is a 36-year-old who has stage 2 to 3 fibrosis and a very high chance of progressing to cirrhosis by the time she's 40. So this is a patient that had an incidental finding of fatty liver on imaging, who we absolutely need to manage aggressively. In terms of fatty liver in Latinos, well, we know that NAFLD has a variable prevalence and severity across different ethnicities. This is in part an interplay between genetic factors, lifestyle factors, and the presence of chronic metabolic diseases. So we see differential carriage of that single polymorphism of the PNPLA3 gene, in addition to higher rates of visceral adiposity and type 2 diabetes in certain populations, namely Latinos. So the prevalence of NAFLD in Latinos living in the United States is 45%. And if you break that down by kind of geographic region, it's actually a 60% rate from Mexico, less so in Central and then South America. We see a 33% prevalence among non-Latino whites, a lower 24% prevalence among non-Latino blacks. And we know that Asian Americans have not necessarily the highest prevalence, but we see fatty liver at much lower body mass. So a BMI of 25 is considered obese in some Asian Americans. And so we just have to have a higher degree of suspicion. And we know that Latinos have an earlier presentation, a higher proportion of NASH versus benign steatosis, and a more rapid progression to fibrosis. So Elena is not alone. This is actually a very, very common case. So in terms of management, this is not a talk about NASH management because that actually requires its own CME, but we can keep it really simple. So I would say there's 6 things that we should consider. 5 to 10% total body weight loss. It does not matter how you get there. Increased physical activity, improved diabetic control. We think about adding vitamin E if a patient is non-cirrhotic and has no contraindications. At this point, we need to consider clinical trials because there's been nothing yet approved for the pharmacotherapy of NASH. And then we want to consider bariatric surgery that I'll mention. This is a complex slide that really illustrates the multiple pathophysiologic pathways of NASH and that there are multiple different targets that are being targeted by the pharmaceutical industry to try to find the first pharmaceutical agent for NASH, which will obviously be a huge blockbuster, and given the prevalence, likely be quite the lucrative medication. But we know that from the clinical trials so far, we've had a lot of phase 2 to 3 trials, that single agents don't perform as well as likely combination therapy will in the future. But I will say that in 2021, we are likely to see the first approval. An FXR agonist called obeticholic acid that we're using currently as an adjunct for PBC is likely to be approved as the first medication for NASH. But in the future, I think we're going to see the importance of combination therapies in addition to the importance of weight loss along with that. At this point, bariatric surgery is absolutely the most efficacious management strategy for NASH. It's associated with the disappearance of steatohepatitis in 85% of morbidly obese patients. It has the highest chance of reversing fibrosis. But when we think about candidates for bariatric surgery, patients that have decompensated liver disease are not candidates. So you really need to catch these patients early. And someone like Elena with stage 2 to 3 fibrosis would be the best candidate to prevent her from getting to cirrhosis, in addition to decreasing her cardiovascular risk and her risk of progressive diabetes. One point of caution that I think is very under-recognized is that we're seeing a significant increase in the risk of alcohol use disorder in the 5 years following bypass surgery. So it's not entirely clear why this is happening. Is it replacing one vice with another? But we know that there's a significant impairment of metabolism due to gastric bypass plus weight loss. So you have a lower volume of distribution. You're basically bypassing the first pass metabolism by not having that, those good antral cells. So these patients get more buzz and they can actually get quite intoxicated on just one drink. So there's cases of patients getting DUIs a couple weeks following bariatric surgery from having one drink. So we see this cases of progressive liver injury and even fibrosis quite rapidly in the 3 to 5 years after bariatric surgery due to very minimal amounts of alcohol. So I would just underline the fact that counseling is key. There is no safe amount of alcohol use after bariatric surgery. Patients should really be counseled that they need to be abstinent entirely. So this brings us to our second case. So this is our Korean American executive that has mixed metabolic and alcoholic risk factors, and his ultrasound is concerning for cirrhosis. So in a patient that has both risk factors, how do we know if it's the fat or the alcohol that's causing the problem? And it's difficult because the definition of significant alcohol use remains debated. And currently the cutoffs for non-alcoholic fatty liver is any man that drinks less than 30 grams or 3 drinks per day, and women that drink less than 2 drinks per day. But that classification into separate groups is fairly arbitrary and often inappropriate in patients that have low level or low risk drinking, because we know that low amounts of alcohol can still cause steatosis and injury in patients with other metabolic risk factors. So this spectrum of liver injury is quite similar. We see this same range of steatosis, steatohepatitis with progressive fibrosis, but often patients do have fairly different clinical presentations if they have true alcohol-related liver disease or true metabolic fatty liver disease. Though diagnostics can be difficult because the imaging looks similar, fatty liver looks like fatty liver. Histologically, these can be indistinguishable. There are a few differences that you can see in this diagram here for alcoholic steatohepatitis, including a higher infiltration with polymorphonuclear cells. Oftentimes we see a more significant amount of ballooning, and then we see more macrovesicular steatosis in NASH. However, oftentimes these things look the same. So your history is really key. The amount of alcohol, the duration, the type, the timing, what is the patient's nutritional status. So you really have to ask more than just how many drinks a day your patients are drinking. So I mentioned earlier that there has been a bit of a push to update the lexicon and change non-alcoholic fatty liver disease to metabolic associated fatty liver disease, to take that non out of it, because a lot of times there is some degree of alcohol and it sort of implies that this is maybe not a progressive condition. So potentially avoiding a little bit more stigma that we associate with some of these terms. This has been recommended by several societies. However, this is not, it has not been taken up at this point. So we are still calling this NAFLD, but I do predict in the future that we will be changing this to metabolic associated fatty liver disease, which I actually agree is probably more appropriate. So back to fat and booze. So we know there's a high prevalence of obesity, there's a high rate of alcohol consumption worldwide, and frequently we see both of these conditions in the same individual. Well, our natural history studies suggest that one condition is usually predominant while the other is a cofactor. So it's really about teasing out which is the driver, because common pathways lead to steatosis regardless of kind of the etiology. Imbalance of fatty acid synthesis and beta oxidation, inflammatory immune response, as I mentioned, intestinal permeability and dysbiosis, in addition to the same genetic predisposition for alcohol and non-alcoholic fatty liver disease. It's the same genetic polymorphisms. So we see this synergistic increase in fibrosis progression when there's fat and booze. And these patients are at much higher risk for liver-related death and liver cancer. We also know that the combination of metabolic and alcoholic risk factors increase the risk of cardiovascular disease and cancer. So there appears to be just this really important interaction that has been less appreciated in the past. So we see this overlap, but we also know that there's synergy. BMI is the strongest independent predictor of liver fibrosis among daily drinkers. For example, we see a 5.8-fold risk of steatosis in daily drinkers who are also obese. For obese women who drink more than 150 grams per week, they have a 5-fold relative risk of cirrhosis. Among heavy drinking Japanese men, the presence of diabetes increased liver-related mortality by 8-fold. And in alcohol-related cirrhosis, the risk of liver cancer increased 6.7-fold with obesity and type 2 diabetes. So these are not additive risk factors. And in fact, this binge drinking and visceral fat synergistically promote liver injury through these same pathways that are just exacerbated. So what about moderate alcohol? So in the 90s, there was a lot of talk about the sort of protective effect of low-risk drinking in terms of cardiovascular health. And you can see up top, my doctor said 1 glass of wine a day was good for me, but people can take this to extremes. So in the early 2000s, we were looking a little bit more into what is the protective effect of fatty liver, or the protective effect of low-risk drinking in those with concomitant fatty liver. It's an interesting question, right? Because these are patients that die of cardiovascular disease. So anything we can do to augment or improve their cardiovascular risk profile is going to be an important finding. And initially, some studies did suggest a cardiovascular benefit. But over the past decade, there's been a much more overwhelming amount of evidence that really concludes there is no safe alcohol threshold for patients with concomitant fatty liver. So a large study of Korean adults with NAFLD, over 58,000 patients that were followed for 5 years, showed that light to moderate alcohol use was associated with a significant progression of fibrosis, and this association was stronger for more obese individuals. So this just underlies the fact that these are contributing factors, and that lower amounts of alcohol are going to be more toxic in patients that already have that metabolic associated fatty liver. And I would say, in contrast to the general population, alcohol use does not reduce the cardiovascular risk in patients with NAFLD. However, there's also a lot of evidence accumulating that there's probably no safe threshold for alcohol use when it comes to overall risk in terms of things like colon cancer, breast cancer. And so while I personally only think about the liver, there are the other impacts of heavy drinking over and above the risk of liver disease that need to be considered. So when we get back to case 2, our patient with mixed alcoholic and metabolic hepatitis in addition to a nodular liver, what will have the biggest impact on his natural history of liver disease? So if he cuts out alcohol but doesn't lose weight, what will happen? If he continues to drink but loses 30 pounds and resolves his diabetes, what will happen to his liver? So in this patient, we decided to biopsy him because his liver enzymes were high, his ferritin was high, and we do see steatohepatitis with stage 4 fibrosis or cirrhosis. But this patient had an overwhelming number of PMNs, so this kind of neutrophilic inflammation, which is more consistent with alcohol-related injury. So we hypothesized that for this gentleman, his 3 to 4 whiskeys a day were probably the main driver of steatohepatitis, and that the metabolic syndrome was the cofactor. But this is obviously something we're never going to prove. And as we know, these patients with these dual risk factors have very, very high rates of progressive disease. And in fact, if you think about the risk of hepatocellular carcinoma, the risk is about 5 to 6% per year for patients that have cirrhosis and these mixed risk factors. So if this gentleman lives from age 60 to age 80, he is more likely than not to develop liver cancer. And accordingly, 6 months later, his ultrasound shows a 3-centimeter mass. So for this patient, how do we manage this? And we think about, first and foremost, is he a candidate for liver transplant? And as I mentioned, NASH is the leading indication for liver transplant in women and second only to alcohol use for men. But there are limiting factors here. So is this patient actually able to stop drinking? He needs to be sober for somewhere between 3 to 6 months to be considered. And is this patient able to lose enough weight or manage his sort of cardiovascular risk profile to the point where he's also considered safe for transplant? So there are significant limitations to achieving transplant in these patient populations that I think it's really important to acknowledge, because transplant is not a possibility for the vast majority of people with cirrhosis and those who develop liver cancer. So moving on to our last case, where we're focusing more on alcohol. So non-alcoholic, mixed alcoholic, metabolic, and now Cheryl is a 54-year-old Caucasian mother of 3 who presents with jaundice, upper abdominal discomfort, and her primary care provider sends labs and her bilirubin is 3.3. She has no known history of liver disease. We look back at her labs and her MCV has been elevated pretty much consistently. Her AST has been in the 40s to 50s, but she's never been told that this may be a problem related to drinking. She had been drinking 2 glasses of wine per day. Keep in mind that everybody does underreport. It's actually pretty well documented. It's not an assumption. But during quarantine, her use went up to a bottle to 2 bottles of wine per day. This is also not an uncommon story. So we're seeing increased rates of alcohol dependence and alcoholic liver disease among women, and this did predate the COVID pandemic. So let's start off by defining risky drinking. So a standard drink in the United States contains 10 to 14 grams of alcohol. So if you look at the chart up top, that's 10 to 12 ounces of beer, a 5-ounce pour of wine, 1 shot of liquor, or 1.5 ounces of, I don't know what that brown liquor is. At any rate, we're looking at about a shot of hard alcohol. So if you're ordering a martini, that is not 1 drink. That can be 2 to 3 standard drinks according to these guidelines. Moderate alcohol use is going to be 1 drink a day for women and 2 drinks a day for men. This is considered low risk. We would not assume that there would be any kind of liver-related ill effects from this amount of drinking. Binge drinking is defined as 4 or more drinks per occasion for a woman or 5 or more drinks per occasion for a man. Heavy alcohol use is defined as binge drinking more than 5 times per month. And alcohol use disorder is this more kind of subjective definition, use of a large or escalating amounts of alcohol with unsuccessful efforts to cut down, time spent recovering from obtaining or using alcohol, recurrent alcohol use when physically hazardous, craving and withdrawal, and the accumulation of more symptoms results in more severe alcohol use disorder. So those are our definitions, and we know that across the board in the United States, drinking across all categories of use has increased in the past 2 decades. We see that high-risk drinking has increased by 30%, with more marked increases among women and minorities. Alcohol use disorder has increased by 50% in a 10-year time frame, now affecting 1 in 8 Americans, and much more concerningly, 1 in 5 Americans aged 18 to 29. We also see an 80% rise among women. So these are very concerning statistics. So when we think about the pathways of alcoholic liver disease, this looks really similar to non-alcoholic liver disease. We see this progression. So in a patient that has chronic alcohol consumption, they're likely to develop some degree of alcoholic fatty liver or steatosis. Steatohepatitis is the more significant necroinflammatory response, and of course what we see in the hospital is acute alcoholic hepatitis that can be the first presentation of alcoholic liver disease in a lot of patients. And if patients continue to drink through this pathway, they're likely to develop cirrhosis and liver cancer. But we know that not all patients that drink heavily will develop any clinically significant liver disease. And in fact, a study out of Italy called the Dionysus study looked at over 13,000 patients who drank more than 10 drinks per day. And only 13.5% of patients who drank 10 or more drinks per day developed any clinically significant liver injury. So we know there are modifying risk factors, and that genetics, sex, ethnicity, presence of obesity or underweight, nutritional status, and other concomitant liver diseases are going to play a role here. And it's really just to say that not all patients that drink heavily will develop liver issues, but as I mentioned before, there are other concerns about heavy drinking, including cardiovascular risk and cancer, that we have to also keep in mind. And you know, some patients can roll the dice and never develop any liver problems, but we just aren't that good at predicting it. So we need to really start to understand how to counsel our patients about what a safe level of drinking is. So if we know that rates of alcohol intake are going up, it's fair to assume that rates of alcohol-related liver disease are also rising, and that is the fact. Alcoholic cirrhosis has increased significantly over the past 20 years. At this point in time, alcohol is responsible for 50% of liver-related mortality. Alcohol-related deaths doubled between 1990 and 2007 and are still rising. And we see this very high burden of care for alcoholic cirrhosis. So we've seen a doubling of hospitalizations over the past decade, and compared to patients with non-alcohol related cirrhosis, we see a much higher cost of care, readmissions, ICU admissions. These patients are heavy users of the healthcare system and tend to be very sick and not do well. This is the leading indication, as I mentioned, for transplant for men, and the second for women. So also kind of a use of resources in that manner. What about alcoholic liver disease in women? So we know that for the same level of alcohol, women have an increased risk of cirrhosis. So for the same amount, the relative risk of drinking 48 grams per day, 4 to 5 drinks per day, the relative risk of cirrhosis is double for that of men. And so if women are keeping up with their male counterparts, they're going to get into trouble. Women also develop alcoholic liver disease on average 3 to 5 years earlier. And women are more likely to present with severe alcoholic hepatitis without any prior diagnosis of alcoholic liver disease. The question there is there a diagnostic bias? Are women underreporting, or is there just a lack of, assumption by primary care or other providers that this may be an issue? But we know this to be the case. In the U.S., over the past decade, we've seen that the largest increase in alcohol-related deaths are among non-Hispanic white women. So we need a higher index of suspicion, assuming that women, along with men, do tend to underreport and don't tend to ask for help as often. So why are women drinking more? Well, norms around drinking and what's socially acceptable for women have changed dramatically over the past century and really over the past 10 to 20 years. Alcohol is everywhere. So you see it in TV, movies, all over social media. We've seen a really concerning increase in direct-to-women consumer advertising. So you see at the bottom this skinny girl martinis. You can drink and also stay thin. There is a lot of marketing to women. This is a big business for the alcohol industry. We also know that women drink more in response to negative emotions and anxiety than men do. Women tend to cope more with alcohol. And let's be honest, COVID has been really hard on women and moms in particular. Another aspect of this that most of you have probably heard of is this idea of mommy juice culture. So women, younger moms, drinking to cope with the stress and sometimes isolation of being either a stay-at-home mom or a working mom who is dealing with these increased pressures. So these are just some of the things you can easily find on the internet, but the glass says, because my kids stress the hell out of me, mommy's sippy cup. If you combine wine plus dinner, the new word is winner. This type of culture is really everywhere. And a personal story, when I was putting this talk together, thinking back about when I was in a mom's group for new moms through Swedish Hospital with the birth of my first child 5 years ago, every single gathering related to or revolved around alcohol. Even the morning play dates had mimosas. So this is a very real thing. I see this in my friend groups. I see this on social media, and I think it's really important that we acknowledge that mommy juice culture is probably not healthy, and that these may not be the women that end up in the hospital with alcoholic hepatitis, but this is dysfunctional drinking, and it just should not be as normalized in culture as it is currently. So what about COVID-19 and alcohol? So mommy juice culture has been around for a long time. So this is not something that's new or different, but likely has been exacerbated over the pandemic. But in-person liquor sales soared by 55% in March of 2020 compared to the year prior. But online alcohol sales rose 300% during the first 2 months of shutdown. So we know that boozing at home and Zoom happy hours are fairly standard place. Zoom happy hours are normal in my family. Regular drinkers reported consuming 3% more than they did pre-pandemic, and women reported a 40% increase in binge drinking. So this is concerning. The images on the right are from a company called Drizzly that advertises beer, wine, and liquor delivered in under 60 minutes. Let the drinks come to you. And, before COVID, this company's been around since 2019. And then in the first 3 months of the pandemic, this company saw a 10-year growth in 3 months. So this company is doing very, very well. It's a bit sad that mom and pop restaurants are closing and that online alcohol sales are booming, but this is what we're seeing at this point. So this data isn't published yet, but in terms of COVID-19 and alcohol-related liver disease, there are position papers from several institutions, including USC and NYU, reporting that rates of admissions for alcoholic liver disease increased by 30 to 50% since March of 2020. And we are seeing this here at Virginia Mason. I think there's not a resident in the hospital that hasn't pronounced death in a 20 or 30-year-old with acute alcoholic hepatitis over the past year. We are seeing a very significant rise in our hospitalizations for alcohol-related liver injury, and anecdotally, we're seeing a lot more in younger patients and women. We also are seeing high rates of relapse among previously stable patients with alcoholic cirrhosis. They've been sober for 10 years, pandemic hits, and they start drinking again. This can lead to high rates of delisting for patients listed for liver transplant. Stable alcoholic cirrhosis, they're doing well. Transplant institutions have reported very high rates of delisting that they have not seen previously. We also know that the age of those hospitalized, as I mentioned, is dropping alarmingly. So binge drinking affects 20% of 18 to 29-year-olds, and we are seeing these patients in our hospital very, very ill. So I think you can ask, why is COVID associated with increased alcohol-related liver disease? Well, I think it's fairly obvious. Isolation, unemployment, hopelessness, and for those with chronic alcohol addiction issues, there's now less structured activity. There's increased anxiety. There's lack of social and family support. AA and online and support meetings were canceled or went online, and that's not going to be accessible for all of our patients that suffer with this disease. So we're seeing a very alarming trend here. And if we think about the fact that we may all be vaccinated, but the economic decline associated with the pandemic is likely to continue, this problem is not going to go away. So if we go back to our patient Cheryl, our 54-year-old mother of 3, so she has a clinical diagnosis of mild to moderate alcoholic hepatitis, which for a lot of patients is reversible with the appropriate management. But how can we support this woman's sobriety going forward? And where do we go from here? So we could talk about, naltrexone, antabuse, cognitive behavioral therapy. But if we think a little bit more from a sociocultural perspective, we know that women are bearing the biggest burden of domestic stresses, now homeschooling, childcare, keeping the household from falling apart in these difficult times. A concerning study recently showed that 74% of moms say they are mentally worse off now since before the pandemic. And we know that daily alcohol use has historically been a socially acceptable coping strategy for women. So we need to improve our options for self-care. We need to improve the ways that we can support stay-at-home and working moms throughout this conflation of a pandemic, in addition to rising rates of alcohol abuse, rising rates of obesity, and the significant both liver and mental health manifestations that can come from this. So in conclusion, we see the same pathways of inflammation and injury for these really different types of patients. So Elena, who is our Latina, BMI of 34, age of 36, who is on her way to cirrhosis. Lee, who already has cirrhosis from mixed alcohol and metabolic risk factors, goes on to develop a liver cancer. And Cheryl, who presents with acute alcoholic hepatitis, having never been diagnosed with any fatty liver or alcohol-related issues previous to this. So we see the same pathways of inflammation and injury, and we see the same spectrum of disease: steatosis, steatohepatitis, cirrhosis. And we know that with rising rates of obesity and alcohol dependence, which are exacerbated by COVID, these 3 problems are not going away. So we need to think a little bit more about societal level changes in addition to getting these patients into hepatology clinic. That is all I have. My email and my cell phone are listed here, and I'd be happy to entertain any questions.